everyone, and thank you for joining us for today's MQii Learning Collaborative Participant Dissemination Workshop. We are very thankful to have you all today as we share some insights and guidance regarding producing and disseminating your malnutrition quality improvement research and some great tips and tricks for putting together abstracts or publications with the goal of potentially submitting to an exciting opportunity that we have with the Journal of the Academy of Nutrition and Dietetics for a special malnutrition quality improvement focused supplement due in September 2019. I am Kelsey Jones. I am one of the MQii leaders at Avalier, and we are joined by Catherine DeAndrea from the Academy, who will share a little bit about the JAND supplement opportunity, and then two expert speakers who will go into some description of how to put together your research and then how to package it up for dissemination opportunities. Before we get started, I wanted to share a couple of quick housekeeping items. If you have any questions for any of the speakers at any point during today's session, or if you're running into any technical issues, please do contact us via this chat function. You can see it in the upper right-hand corner of your screen. Some newer WebEx platforms show a similar kind of comment bubble down at the bottom center of your screen if you scroll your mouse over it. So please use the chat or Q&A function to send us any questions, or if you're encountering any technical difficulties, you can reach us that way as well. Your lines have all been muted upon entry, so this is how we will gather questions, and then we'll hold all questions until the end of the session, at which time we will pose them to the speakers. So as I mentioned, first we'll have a quick overview of the JAND supplement opportunity. This is an exciting and unique opportunity that we have with the Journal of the Academy of Nutrition and Dietetics to highlight some of the great malnutrition quality improvement work that you all are doing. And that portion will be led by Catherine DeAndrea from the Academy of Nutrition and Dietetics. And then we'll have a few examples of research and dissemination opportunities led by two leaders within Catholic Health Initiatives, Amanda Goldman and Sharon Siegel, and we'll wrap up with questions at the end. You can see our speakers here. And without further ado, I'll turn it over to Catherine to lead us through some information on the JAND supplement opportunity.
All right, great. Thank you, Kelsey, and thank you everyone for joining us today. As Kelsey mentioned, this is a very exciting opportunity, and I'm happy to be here to share some of the information with everyone regarding the MQii focus supplements. Abstracts will be featured in an MQii focus supplement of the Journal of the Academy of Nutrition and Dietetics, as Kelsey mentioned, to be released in September 2019. The JAND supplement intends to highlight MQii stories and learning collaborative member findings. It will be peer-reviewed, and it's being led by the Academy and Avalier with support provided by Abbott. The supplement will feature both articles and abstracts documenting the importance of multidisciplinary malnutrition quality improvement and its impact on outcomes. It is an exciting opportunity for learning collaborative members to promote themselves, their teams, the organizations they work within, also to increase awareness of malnutrition, advance the nutrition dietetics profession, also to promote the role of the registered dietitian, and to support a culture of quality in healthcare. Before I go into some of the specifics of the focus categories for the abstract for this specific supplement, I just want to draw attention to the orange call-out box on the bottom of this slide. Sherry Baird presented on a previous dissemination webinar on February 13th and did an excellent job of outlining general abstract writing information and tips. That information is located, or the recording of the webinar is located on accessing the link below, as well as the handout that includes abstract writing tips and submissions. For this specific JAND MQii focus supplement. Abstracts should be based on experience with and/or use of the Malnutrition Electronic Clinical Quality Measure and/or Malnutrition Quality Improvement Initiative Online Toolkit or other quality improvement frameworks, and be relevant to malnutrition in the adult acute care population. Abstracts should be aligned with and be submitted for one of the categories listed on this slide. The first being multidisciplinary team engagement and key learning from implementing a clinical malnutrition-related quality improvement process or program. Abstracts should include information about the learning objectives, need or purpose for implementing such a process or program, background about the quality initiative development and/or the implementation setting, the quality improvement tools and/or process on which the initiative is based, as well as results and key learnings, conclusions, and of course, implications for dietetic policy or practice. The second category for focus abstracts for the supplement is data integration and process outcome results from implementing a clinical malnutrition-related quality improvement process or program. Abstracts for this category should include information about the purpose for implementing such a program or process, the relevance to dietetic practice, background about the quality initiative development and/or implementation setting, methodology for the quality improvement initiative, including data sources, data integration techniques, and/or process outcomes measured, results or process outcomes, conclusions, and implications for dietetic policy or practice. The third and final category for submission to the supplement is research outcome results from implementing a clinical malnutrition-related quality improvement process or program. Abstracts for this category should include a brief description of the author's original objective or hypothesis, the relevance to dietetic practice, background about the implementation setting, research methodology, including the design and research outcomes measured, results and research outcomes, conclusions, as well as the implications for dietetic policy or practice. And as a reminder, we mentioned, or this was brought up on the previous webinar, but the QI projects do not have to be, or the abstracts submitted do not have to be from formal research. QI projects are strongly encouraged, and actually only the third of these three categories is focused on formal research and includes research outcomes. And again, they could be at early stage or late stage in the QI process. So an early stage example would be prior to data comparison. That would be during a milestone during the QI process. And a late stage would be after pre and post data comparison and at the end of the QI process. Some examples: if your team had a story to share that included building a team within an organization to improve malnutrition care, or creating a process to engage leadership on QI efforts related to malnutrition screening, those would fit as an early phase in the category multidisciplinary team engagement and key learning. Examples for data integration and process outcome results would include introducing malnutrition data elements into EHR for ECQM data collection, or addressing challenges associated with improving nutrition screening using MST in the EHR, improving malnutrition screening rates. To qualify for research outcome results abstract, it must include outcomes data, so a malnutrition pilot or QI activities with outcomes data. For example, malnutrition patient outcomes that include improved length of stay, readmission rates, or weight status. Okay, some of the JAN submission guidelines and requirements. All abstracts are going to be submitted via an MQii JAN supplement submission website or link. That link is going to be shared after this webinar. More information on that to come. Abstracts may be 250 to 500 words in length. Abstracts must be submitted using one of the template guidelines. Submit all information listed on the form, including the funding source if there is one. If a student is going to be submitting an abstract, the name, email, and phone number of a facility advisor must also be included. And all abstracts must be of original material. And the material may not have been previously printed, published, or presented prior to September 2019. Research results and conclusions must be completed at the time of submission, and as always, it's important to proofread your abstract carefully. It's important to point out the Academy Quality and Avalier team will be with you to help you along the way in supporting you in preparing to submit an abstract. On this slide, it does call out in the second bullet point, the link for abstracts will be open from Wednesday, April 3rd to Thursday, April 18th. But we encourage everyone who is going to submit to begin working with the abstract templates that will be sent out after this call. They'll be in a Word document, so you'll be able to type your information directly onto that form. And any questions or if you need any further information, please reach out to the quality@eatright.org email. And again, we are here to help you along the way. When the submission link is open, it will be sent out via the MQii dish to all Learning Collaborative participants. And there will be a handout with all of the submission guidelines and requirements along with the templates that I mentioned that will be available after this webinar. And just to reiterate, the previous webinar that was on September 13th was from Sherry Jones. Sherry Jones did an excellent job of presenting general abstract writing information and tips. And that information back on slide 5 is a link to that webinar. So again, thank you, Sherry Jones, for the previous webinar. And that concludes my part of the presentation. Again, please reach out to the Academy and Avalier teams with any questions, and please begin thinking about your submission and typing it into the Word document sooner rather than later.
Great. Thank you so much, Catherine, for walking us through those requirements and giving us a sense of what will be expected for this JAN supplement opportunity. I do really want to encourage any of you who are on the phone with us today to please consider submitting an abstract for this opportunity. As Catherine said, the Avalier and the Academy teams are here and ready to help you think about what might go into that and what story you might wish to highlight. And we would really love a robust kind of varied view of what all the different MQii sites are doing. So we really do hope that you all will consider submitting an abstract for this opportunity. We are now very pleased to have 2 expert speakers join us to share some insights on how they introduced a malnutrition quality improvement program at Catholic Health Initiatives, or CHI, and then subsequently conducted research in disseminating their findings, including successful submissions to the Academy of Nutrition and Dietetics. First today, we'll hear from Amanda Goldman. Amanda obtained her BS in Dietetics from Miami University and her MS in Clinical Nutrition from the University of Kentucky. She completed her dietetic internship at UK Hospital, and she is the System Director of Quality and Wellness for the CHI Food and Nutrition Services National Program. Along with her current position, she is also the Director of Diabetes and Nutrition Care for CHI St. Joseph Health. Amanda is a past president of the Kentucky Academy of Nutrition and Dietetics and is a past chair for the Management in Food and Nutrition Systems Dietetic Practice Group of the Academy of Nutrition and Dietetics. We'll then hear from Sharon Siegel. Sharon is a System Clinical nutrition manager with Sodexo, who has over 25 years of experience as a registered dietitian in healthcare. She leads the clinical nutrition team of the University of Louisville Hospital and the Western Market of Kentucky One Health Hospital System, a division of Catholic Health Initiatives. She earned a bachelor's degree in nutrition and dietetics from Louisiana State University and currently serves as the secretary of the Kentucky Society for Parenteral and Enteral Nutrition and resides in Louisville, Kentucky. So thank you, Amanda and Sharon, for providing your insights and guidance, and we look forward to hearing about your research.
Great. Thank you so much for having us. We really appreciate the time on the webinar agenda today, so thank you. So this is Amanda Goldman, and I'm going to start us off for our section. We'll be talking a little bit about some malnutrition research that we've done, and you can see on the screen there specifically about improving patient outcomes and decreasing hospital costs through nutrition. You can see the learning objectives that we have there. At the end of this particular part of our session, we'll be talking about describing the importance of a comprehensive malnutrition program and its impact on quality outcomes, including morbidity, mortality, and readmissions. We're going to explain how to lead an interdisciplinary team to promote best practices and implement strategies to improve data collection, as well as enhance reimbursement. And then also just a general understanding of the process to translate into a research project into an abstract or a manuscript. So just a little bit of background about Catholic Health Initiatives. We are actually the third largest nonprofit health system in the United States. And actually we just recently merged with Dignity Health to become Common Spirit Health, and so now we're the largest Catholic health care system within the U.S. Specifically today, we'll be talking about some work related to the CHI side of that. We're located in about 18 states with over 100 hospitals and clinics, over about 90,000 employees, and then one of our missions and our focus is really to help to build healthier communities. So also some background about us. About 5 years ago, we started developing a standardized nutrition services program. Really, in the thought process there was to how can we consistently provide food and nutrition services across our enterprise. And so at that point in time, it was determined that we partnered with Sodexo, and with that, we now have our national nutrition program in about half of our facilities, half of our markets across the United States. And so you can see on the screen there, we've got the puzzle pieces of all the facets, if you will, that kind of fit into a food and nutrition services department, including financial, IT standards. Obviously, community health is a big piece of what we're talking about today, patient experience and patient satisfaction, and then also the clinical piece and how specifically our dietitians work together with our physicians as well as with nursing staff members. So for the purpose of the conversation today, obviously we know everybody on this call, knows what the definition of malnutrition is. We know that it is that unhealthy condition resulting from not eating enough food or not enough of the right food, if you will. In an acute care setting, just to give some background to kind of set the stage for our research, we went into this knowing that malnutrition impacts about 30 to 50% of hospitalized patients, and have even seen some recent articles and research studies that show that that percentage may even be higher than 50%. Generally, we know that about only 3% of those patients historically have had a medical diagnosis on discharge by a physician. And before we started our research and really implementing our program, we wanted to kind of find out where were we? Where did we fit in, within that 3%? Were we close to that number or not? So we worked with our clinical analytics team, and it was determined that actually less than 2% of the hospitals at that point in time that made up Kentucky One Health, which is a multi-hospital system within the state of Kentucky, had a documented medical diagnosis of malnutrition. So we were actually lower than the national average of that 3%, which is a pretty large gap when you're comparing that to the 30 to 50% range. And just a little bit of background about Kentucky One Health. That is one of the markets within Catholic Health Initiatives. It's made up of about 11 hospitals primarily in the Louisville area as well as the Lexington and central and eastern portion of Kentucky. We've just recently gone through some branding changes. The Louisville market is still considered Kentucky One Health. The central eastern market is considered CHI St. Joseph Health. But for the purpose of today, we were all under the Kentucky One Health umbrella at that point in time. So when we're thinking about implementing a malnutrition platform, we know that there's a lot of stakeholders in that process. Who's going to help us to share in that vision and really help to champion and really support and have some buy-in to our program or to any initiative with respect to clinical nutrition and malnutrition? So we know that nursing is huge in that quest, and that's a group of folks that we definitely want to get involved very early on. And then also, obviously, in addition to our dietitians, members of our discharge planning teams, our CDI and coding teams, any folks from quality are great to have on board and have that support. Obviously, all of our physicians, and it's great to have a physician champion that really backs that at each facility if possible. And then we also work closely with some of the rehab departments, wound therapy, and then obviously we know that we need administrative support and buy-in from our senior leadership teams, as well as IT, if there are any changes that need to be made from an EMR platform standpoint. So a little bit about our comprehensive malnutrition platform. We want it to be an inclusive approach. That's really the intent. We know that we're not going to be successful if we don't work across various disciplines. And so it is our goal, obviously, to identify malnourished patients using the evidence-based standards. We want to make sure that our dietitians can really help the physicians to determine the type as well as the severity of malnutrition. So we know generally that physicians feel pretty comfortable with identifying malnutrition, but not necessarily knowing the severity and the type. And that's really one of the large reasons that we have our dietitians to go through this, in addition to obviously providing better quality care and really helping to improve outcomes of our patients. With the platform, we have a comprehensive documentation protocol for our team, specifically for the dietitians, and we know that the documentation is absolutely critical in that piece. That's really going to help to guide the physicians to document the correct medical diagnosis in terms of a malnutrition standpoint. And then the training that we offer for our dietitians as well as our other team members. We want our platform to complement the use of the malnutrition screening tool. So this is not the same as the malnutrition screening tool. We do have that in place within the facilities that we performed the research and we were implementing it at that time. But this really kind of works side by side. It really supplements the use of that screening tool that is actually completed by nursing staff members. We want to make sure that we're assisting, enhancing reimbursement back to our individual facilities, and then really tracking what our outcomes are and also tracking the number of patients that our dietitians identify with malnutrition, as well as the number and percentage of patients then that the physicians then document a medical diagnosis for those specific identified individuals. We know that our platform really helps to decrease the risk during a RAC audit if we ever should have one, hopefully not, but if that ever is the case, we know that will be helpful with respect to documentation. And then obviously, with performing the nutrition-focused physical assessment and having that enhanced training, that really does improve the skill set with which our clinical dietitians practice on a daily basis. And it really gives them a seat at the table from a senior leadership perspective, which is definitely something that is beneficial. Some of our platform features with respect to the clinical dietitian training, including that NFPE workshop that we provide. It's a pretty intense 8-hour session that we have classroom training in addition to skills hands-on training. And also during that training workshop, we go over what the program policy and procedure will be specific to that facility. We go over our outcomes, our tracking, and we also discuss audits that we do on a regular basis after we have implemented the program within a specific hospital. We do also offer a condensed version of our training to physicians and nursing team members, as well as our CDI teams and our coders. And really kind of why is that important? We know from a dietitian's perspective, documentation-wise, that it really provides that accurate picture of that patient's condition. It really helps to support the interdisciplinary care provided by the patient and ensures reimbursement back to the facility. So during that workshop, we do spend some time going over with the dietitians about what a DRG is, what a comorbidity and complication is, the CCs and the MCCs, so they really have an understanding of how their documentation fits in to the clinical documentation specialist standpoint. That's very helpful going forward. And then one other slide with respect to being effective for our program. How do we know that it's effective? And so there are some things that we do, and I referenced it a second ago when I talked about the auditing, but thinking about how are you going to maintain integrity of your program, how are you going to make sure that you do audit it and recognize areas of opportunities or gaps that may arise, maybe looking at the documentation by the clinical dietitians, is it consistent? Are they using the proper terminology that needs to be? Are the physicians then, acknowledging the documentation and following up with any recommendations that may require a physician's order? So those are some things that we think about and that we look at when we do our audits and really trying to evaluate the effectiveness of that program, in addition to, recognizing if there's a need for further training for a specific dietitian or a specific clinical team. And so I am now going to pass it over to Sharon Siegel, and Sharon's going to talk a little bit more about how we've implemented this program specifically in a couple of the hospitals where she operates. So Sharon?
Thank you, Amanda. I'll be speaking today about another quality component of malnutrition, early nutrition intervention, that was a secondary and integral part of our research. And this initiative really integrates with the nutrition-focused physical assessment that Amanda just finished discussing to form a comprehensive response to malnutrition. And as Amanda mentioned, it was first implemented in 3 hospitals in Kentucky, and we have since expanded this to other locations. The 3 hospitals that I'm referring to include Jewish Hospital and St. Joseph Hospital, which are mid-size acute care hospitals in Louisville and Lexington, Kentucky, respectively, along with St. Joseph East, which is a community hospital in Lexington. And I would like to emphasize also that our research project was conducted over a several-year period. It definitely evolved over time. So a QI project, a research study, an abstract, all of those can be as simple or as complex as desired. The story as to how and why we initiated a comprehensive malnutrition program really began around 2012 with the release by ASPEN and AND of a joint consensus statement, which provided the framework for diagnosing malnutrition. And this used the construct developed by an international guidelines group. Previous to this, there really was no definition of malnutrition, no clear definition. So in the consensus statement, the use of an etiology basis for malnutrition diagnosis is paired with specific criteria of characteristics to define malnutrition. In 2013, the malnutrition screening tool was added to our electronic medical record. And as many of you know, this evidence-based mechanism assesses 2 parameters commonly seen with the diagnosis of malnutrition, those being weight loss and loss of appetite. That same year, an early nutrition intervention or oral nutrition supplement policy was implemented by us as a result of a falls audit, and I'm going to go into some more detail on that. And this was because when we were doing kind of our action plan, we identified malnutrition as a key contributor to weakness, and therefore it increased the likelihood of falls. And then in 2014, a multi-facility task force was established. This was around the time that ICD-10 codes were starting to be talked about, and we knew that they were upcoming. So we wanted to create a task force to examine how moderate and severe protein-calorie malnutrition codes could be used by our clinical nutrition team to identify and document malnutrition in our medical record. And this is around the same time that we started determining how we would appropriately use the ASPEN and A&D criteria and characteristics, and we started trialing that in one of our facilities. In 2015, the registered dietitians at the 3 hospitals we've talked about were trained in the nutrition-focused physical assessment, and we initiated malnutrition coding beginning in January of 2016. And we've also started, right around this same time, preliminary stages of researching outcomes of our multidisciplinary quality improvement initiatives on our malnourished patients. And that culminated in the completion of our study for poster presentation at 3 national conferences last year, and then as well as publication in 2019. So when reviewing the significance of malnutrition intervention, there are really 4 interrelated outcomes that we desired. First of all, research has shown that if an individual is well-nourished and or nutrition interventions are implemented during hospitalization, the likelihood increases that the patient will leave the hospital with a greater nutritional reserve and therefore prevent readmission. Looking at the second parameter, the hospital length of stay, again, we know that early and appropriate nutrition while in the hospital has been shown to prevent or mitigate adverse outcomes, including a delayed length of stay. Third, promotion of quality outcomes and the lessening of adverse health events such as falls and pressure ulcers are incidents that we know are related to malnutrition. And last, an obvious goal is to improve patient care with prompt nutrition intervention. So our research looked at the first 2 outcomes, readmission rates and length of stay, as well as a diagnosis, medical diagnosis of malnutrition. So when you're doing your own research study or your own quality initiative studies, you could easily look at one outcome to measure, such as defining how implementation of the malnutrition screening tool has affected identification of malnutrition or documentation. In developing any quality program, the basic progression includes an initial analysis of steps that are necessary to reach the desired endpoint. So our first step is to recognize and identify malnutrition risk. In our facilities, we require that all patients are screened within 24 hours of admission by the registered nurse using the MST. And then you can see from there, this is our algorithm, that if no malnutrition risk is identified, their malnutrition screening tool score is less than 2, then we don't order an oral nutrition supplement. However, if they do trigger out, then a consult to the dietitian is automatically generated by our electronic medical record, and we want to start a nutrition intervention early to capture as much time as possible with increased calorie and protein provision. So our nurses initiate an oral nutrition supplement 2 times a day, and then when the dietitian completes their assessment, they will implement supplement changes and other nutrition interventions. We are fortunate here in Kentucky. We do have pretty significant order writing privileges established through our medical nutrition therapy policy, and so we have a lot of firsthand input into how we're going to intervene on these patients. At this point, the dietitian also will determine the malnutrition stage if it applies. This is just a view of our malnutrition screening tool in Cerner, which is our electronic medical record, and our EMR will calculate the total score and sending, as I mentioned, a consult to the dietitian and then triggering our oral nutrition supplement protocol. As Amanda mentioned, we do greatly depend on nursing, and so it's important to recognize that in order for this tool or any tool really to be accurate, that accurate information has to be captured. So weight loss, poor intake, needs to be unintentional or unusual for this patient, and this could be another great point for quality data collection. So what performance implementation of a tool such as this or any other evidence-based tool would capture in relation to identification of malnutrition risk. This is just an example of our oral nutrition supplement decision tree. This was developed by a multidisciplinary team early on, as I mentioned, in relation to our fall's audit. The stakeholder services in that team included clinical nutrition, nursing, physicians, speech therapy, care management, and pharmacy, and with the goal to improve patient safety by identifying malnutrition and implementing early nutrition intervention for patients at risk. I should mention that the element of nutrition-focused physical assessment is included in a separate policy that specifically addresses nutrition assessment by the registered dietitian. So this is another piece. When the patient's admitted, the discharge document is initiated so that other disciplines besides nursing can document on it, and the dietitian at this point includes specific supplement recommendations and instructions, reasons why nutrition is important to help recovery, and we found that if information is presented in this way as a necessary component of treatment, then compliance will be greater. So when the patient's discharged, the discharge instructions are given to the patient. And this is, again, another piece. We've conducted quality data collection also in the past with follow-up compliance of discharge instructions, and this could be compared to readmission rate, that sort of thing. Again, just another example that we provide discharge instruction information and printouts, samples, coupons, et cetera, when the patient is discharged. This is just another piece of our whole process. An important component, of course, of any program is compliance tracking and monitoring for the need to adjust methods. And we have access to a report generated by our electronic medical record that assists with auditing the ordering of oral nutrition supplements when patients trigger out on the MST. The report includes information such as which patients were admitted during the date range that had an MST score of 2 or greater, what the score was, the date and time it was documented. Unfortunately, while our nurses are tasked to order the oral nutrition supplement and complete the MST, we're still looking for compliance, especially the oral nutrition supplement part is not a hard stop at the present time. But we're able to also gather information relating to supplement orders, diet orders, malnutrition diagnosis, which is really any active diagnosis entered by the physician that includes malnutrition. So it could be an admitting diagnosis, a working diagnosis, a discharge diagnosis. And this last item particularly assists with quality improvement surrounding conversion to a medical diagnosis of malnutrition. So this data was really just invaluable for our research study. So I'm going to turn it back over to Amanda to discuss the malnutrition program results from our CHI Memorial Hospital in Chattanooga, Tennessee.
Thanks, Sharon. So this slide just shows a sample timeline that we have utilized for implementation of our malnutrition platform. So I do a project timeline similar to this for any of our facilities that we want to implement this program. Generally, from the time that we have a facility interested till the time that we go live is usually a 4 to 6 month process. That generally starts with introducing that program to that market, to that facility, including the dietitians, the food service director, as well as some of the senior leadership team members. Also looking at our policy procedure, are we going to need to tweak that according to the EMR or anything else that may need to be facility specific? We do initial meetings with CDI teams, coders, again, any other senior leaders that we may need to bring into the mix. And then we also, get settled, how are we going to provide that workshop and, set aside a time for that, along with doing the CE training that we offer for the physicians as well as for nursing. And pretty much the last thing that we do is that training workshop. Once we go live with the program, we generally will do an audit 4 to 6 months post go live, and then annually thereafter. And we've actually got some facilities that are coming up due for their audits now, actually, as we speak. On a daily basis, the dietitians will track the number of patients that they identify and the type and severity that they identify of malnutrition for any given patient. So on the next slide, this will show some examples of some of the performance improvement work that they have done down at CHI Memorial in Chattanooga, Tennessee. You can see there that the blue columns are from calendar year 2017 with the red looking at 2018. And there are a few different PI measures that are shown here. So the first set is the percent time that the physician converts a nutrition diagnosis identified by the dietitian to a medical diagnosis. You can see that that improved decently from 1 year over the next. And then also the percent of patients readmitted within 30 days went down. And so that strictly is looking really at a raw number or a percentage number of the number of times that a patient comes back within 30 days. That's something that the clinical nutrition manager at a given facility is going to track. And then the next set goes over the percentage of patients that have received discharge information. So you can see that really improved from a 55% compliance rate to close to a 96% compliance rate. That actually was an area of opportunity that was identified during one of their audits that they really needed to show some improvement on. And so the clinical nutrition manager there and her team really did a great job of implementing a process where they do consistently offer discharge information. And so that's shown a huge improvement. And then the last set of data shows the number of patients actually diagnosed with malnutrition by the dietitian. So you can see there 2017, they started the program during that calendar year, and as they've become more comfortable with it and really better improved their skill set, they've really been able to identify a whole lot more. So really some good PI work done by the clinical nutrition team down in Chattanooga, so I wanted to be able to share that with you all. And then this slide just goes over some general benefits that we have found with our malnutrition improvement platform and program. We know that we've helped to improve some of the clinical outcomes for our patients. We also have seen a decrease in readmission rates slightly there, as well as increase in that patient education that I talked about a second ago at discharge. We are beginning to get some consistent reimbursement information back from our coding teams for a number of our hospitals across the enterprise, and that's something that we're excited about, and it's something that generally our senior leaders are interested in as well. Definitely our clinical dietitians have become viewed as the malnutrition experts, and really that kind of just improves over time as we've had that program implemented within a specific facility. And then, like I mentioned earlier in the topic today, but we really have seen an increase in visibility with senior leaders of our dietitian teams. And there's also just been generally some more interest in the whole topic of malnutrition, specifically from some of the members of our quality departments. And so it's really great to kind of have that increased visibility. And also, one of the things, too, is you can, as I had mentioned on a slide before, is the data that we're starting to get and some of the PI work that our clinical teams are doing. It's really great to be able to see some of the performance changes and improvements after we've implemented this program. And so with that, I'm going to pass it back over to Sharon, and she's going to talk a little bit more specifically about some of the research that we did in those 3 facilities. So Sharon?
Thank you. So our research study was a retrospective cohort study utilizing medical records of over 20,000 patients in the 3 facilities as we indicated. It was a collaborative study with Abbott Laboratories. Jamie Partridge and the Health Economics Outcomes Research and Health Policy Divisions of Abbott were our partners in this study. Our objectives included measuring whether early identification and initiation of nutrition therapy for patients who are malnourished or at risk of malnutrition is associated with reduction in 30-day all-cause readmission rates, if this process will result in reduction in length of stay, and also if the addition of a malnutrition toolkit can help dietitians more efficiently diagnose patients with malnutrition. we compared pre- and post-quality improvement process improvements. So we pulled the medical record information from a number of patients over a 6-month period prior to initiating the quality improvement programs that we talked about today, and then we pulled the medical records over a 6-month period after these initiatives had been put in place and compared the pre- and post-quality improvement process improvements. Our final deliverables included research reports submitted for publication to academic conferences and peer-reviewed journal articles outlining the results of the study. Our principal research findings were a significant decreased length of stay by approximately 1 day. Readmission rates were also decreased, as well as a significant increase in diagnosis of malnutrition post-implementation of our initiatives, and that actually approximately doubled the rate of our diagnosis of malnutrition. I would like to point out we had a wonderful clinical nurse educator who greatly assisted us throughout the process, especially at the beginning with the how to set up a study, the IRB approval, because we were doing this as a formal research project. Just a lot of the logistics and the details that we would not have known otherwise, and she was a huge help. Clinical informatics was also invaluable. They were the ones who retrieved the data for us and really did a lot of work with setting up how we would have all the data that we needed to conduct this. And again, just to point out, this was a multi-year study. One could easily study a single component or a much condensed version of something like this. This is just a list of the abstracts and poster session presentations that we were honored to be accepted at to showcase our research. So the International Society for Pharmacoeconomics and Outcomes Research was in May of last year. The Academy Health Conference was in June, and then Food Nutrition Conference and Expo FNCE was in October. We are also thrilled that our manuscript was accepted by the Journal of Nursing Care Quality for publication, and it is available online through this link already, and then the printed version will be available in July of 2019, so July of this year. So thank you again for joining us today, and I will turn it back over for questions.
Thank you so much, Sharon and Amanda, for that wonderful presentation. It's so fascinating to see kind of how you went from the initial conceptualization of this idea into actually conducting the research and then disseminating it through these various channels. I'd like to remind all of our attendees that if you have a question for Sharon or Amanda or for Catherine regarding the JAN supplement, please do send it to us via the chat or the Q&A function. Your lines have been muted, so you will not be able to ask the question verbally. So please do send us a chat via the Q&A function or the chat function, and we will be able to pose those questions to the speakers. Let's also go one slide down. I believe we have one more quick reminder on some of the abstract recommendations. If you all did not attend the February 13th session, you will, as Catherine mentioned, I would strongly recommend that you all go to the MQii Learning Collaborative portal and view that online, because there's some great content in there. But some quick recommendations and thoughts about reminders on how to submit your abstract, kind of putting it together, making sure it's your elevator or sales pitch for this, for your work. There's a great sentence rule of thumb about how to kind of organize a two-sentence introduction, 4 sentences about the background and the goal, aim, and purpose, 4 sentences about the methods, 4 sentences about the results, and then 2 sentences of conclusion. Please do take a look at that February 13th, and we'll be sending out some handouts and materials after this with additional information on the JAN supplement. Okay, so some questions for the panelists. The first question we have is one of our Learning Collaborative members says, I have some data I could discuss, but I only recently joined MQii. Would that be accepted?
This is Catherine. Absolutely. As a recent member of the Learning Collaborative, you can reach out to the Academy or Avalier. You can email specifically what you're thinking about doing, and we can give you some guidance from the beginning to get you started on the right foot. But you're absolutely eligible and should participate.
There was a second question that came through. Oh, go ahead, Kelsey.
Sorry. When calculating percentage of malnutrition diagnoses, where was this being pulled from? Hospital problem list or final coded diagnosis of malnutrition from your coding department?
Hi, this is Amanda. I'll take that. We worked with our clinical analytics team, and so the percentage of diagnoses we actually can get tracked from them, so that would be on discharge. That's done by our coders as well as our clinical nutrition managers. They're also able to generally check, and depending on what EMR platform they have, to ensure that that was documented by the physician and then generally coded for.
Thanks, Amanda. The next question we received was, were interventions tracked other than ONS supplements from the MST screening results? And did RNs have to enter an actual diet order for ONS, and how was this implemented by food service? So kind of a 2- or 3-part question there.
This is Sharon, and I'll answer that. And can you repeat the first part of that question, please?
Sure. So it looks like the first part was, were interventions tracked other than ONS supplements from the MST screening results? And then did RNs have to enter an actual diet order for ONS, and how was this implemented by food service?
The nurses do enter an actual supplement order, so it is part of the diet order, and that is automatically interfaced with our food service software. So that is how food service gets that information, and that is part of the protocol that we set up in the policy that was approved by our medical staff. So the nurses do actually enter an order. Formally, the only part of our research project that looked at malnutrition screening tool results had to do with oral nutrition supplement implementation. However, we have looked at various pieces and parts that were not part of this research study. We've looked at accuracy. We've looked at whether, compliance as far as nursing completing this. It is now a requirement. So we've looked at different parts. But as far as the research study, that is the only part that was captured in our formal study.
Thanks, Sharon. The next question is, what was the barrier to having a hard stop for the RN to order the ONS after the failed MST?
Primarily our electronic medical record. We would like for it to be a hard stop, but we are on an electronic medical record that is dictated by a large number of facilities, and so the constraints of our medical record were what we were up against, and we are still working through that, but at present it is not a hard stop.
Great. Another question, looks like this one is for Catherine. can I submit my project in the JAN abstract even if, sorry, it's getting cut off here. In the JAN abstract, even if it was submitted and accepted elsewhere, could I use the same methodology but then give updated information as in a phase 2?
Possibly. We'd have to look at that on a case-by-case. JAN does require that it's original information, so it can't be published or printed anywhere else. But we would have to look at case-by-case basis and see how different it would be and if it would qualify to be submitted as different work. So again, you could feel free to email quality@ewrite.org and we can address that directly with the attendee asking the question.
Great, thanks, Catherine. Back to Sharon and Amanda, the next question is, are there any plans to expand similar programs to patients visiting the PCP at private offices?
Well, that's a great idea, but no, we don't at present.
That is a great thought. There have been some conversations about that, but as Sharon just mentioned, we do not currently practice that. That being said, it's probably something that we're looking at in the future at some point. But right now, we're pretty focused on implementing it across our enterprise. So that's going to take us definitely a little bit more time to do.
Okay, and one last question. Have you looked at data of if and how much of the ONS was actually consumed?
Again, not formally, but more sort of an informal basis, and that is a question that we have thought about and looked at, and just the ordering of a supplement, of course, as we all know, does not mean that a patient is going to consume it. So that is a piece that definitely could be studied and could be reported on, but we really have not incorporated that into a formal study at this point.
All right, thank you so much.
So we started with the basic, and that would be a very good piece to study as well.
Thank you, Sharon. All right, well, I really want to take a moment to thank our expert speakers today, Sharon Siegel and Amanda Goldman, as well as Catherine DeAndrea, to share the opportunity with us about the JAN supplement. It seems like this is a topic and research that was greatly of interest to our audience, so really appreciate you all taking the time today. I want to again encourage anyone who is on the line, or if you have any other colleagues working with you on your MQii project, to please consider submitting an abstract to the JAN supplement. It will be a great opportunity to bring some of the benefits that Sharon and Amanda highlighted regarding visibility and highlight your project to your leadership and just kind of elevate the role of the dietitian and the impact of malnutrition. So we do hope you'll consider taking the opportunity to pull together and submit an abstract. We hope that you'll reach out to us as soon as you kind of have an interest in submitting that abstract. We'd be happy to work with you to craft your story and make sure that you're aware of deadlines and things of that nature. Following today's session, we'll be circulating a copy of these slides as well as the recording and some handouts with information on how to get involved, some of those deadlines that we mentioned, some of the next steps, as well as the CPEU credit information. So please be on the lookout for that email from the Malnutrition Quality email, which will contain all of that additional follow-up information. Thank you all for joining us today, and we hope you have a nice weekend.